discuss
This
about secondary
conference will
amenorrhea.
now be recorded.
We'll discuss about secondary amenorrhea. Secondary amenorrhea, it is nothing but absence of a periods for a length of a time which is equivalent to the last 3 months of a cycles, or it is defined as a 6 months of amenorrhea in the absence of pregnancy and lactation. Both pregnancy and lactation are considered as a physiological causes of a amenorrhea. And the other definition, secondary amenorrhea, it is the absence of menstrual periods for a period of 6 months in a woman who had been previously with regular cycles, or for 12 months. Uh, in or If a woman is having the regular cycles, uh, if she is having irregular cycles for a duration of 12 months, this is also called as a secondary amenorrhea. And next is the causes. Secondary amenorrhea, it can be either physiological or pathological. Physiological causes will be pregnancy and lactation and menopause. And pathological causes we'll discuss in detail. Coming to the causes of the physiological amenorrhea, physiological secondary amenorrhea, that is in pregnancy and lactation. In pregnancy, we'll have raised estrogen levels, and HCG will be raised, and FSH and LH, that is gonadotropins levels, will be decreased, and so there will not be any maturation of the ovarian follicles, and there will be no menstruation. And in a lactation, there will be raised prolactin levels. These inhibit the ovarian response to FSH, and there will be decreased GnRH. So there will not be any follicular growth, and so there will not be any menstrual cycles. So these are the causes of the secondary amenorrhea. These are the physiological conditions. And coming to the menopause, women will attain the menopause. There will be less levels of FSH and LH at around perimenopausal age. So there will not be any follicular maturation, and there will not be any menstrual cycles. Next, coming to the pathological causes of secondary amenorrhea, we'll discuss these in detail, and we'll discuss these according to the origin. That is outflow tract causes. That is the uterus, cervix. All these may some pathology in these areas will lead to will cause to secondary amenorrhea. Coming to the outflow, that is genital tract uterine causes. There may be any acquired obstruction, that is due to severe stenosis or atresia of the cervical colon during surgeries like cauterization, chemical burns, or cervical amputation, conization. In all these conditions, there may be some acquired obstruction to the genital tract, or in cases like genital tuberculosis where the endometrium is damaged, there also will have a secondary amenorrhea. And the other cause will be the vaginal atresia due to scarring from a traumatic delivery. In the previous, if she had a delivery, if there is any trauma, there will be in some cases there will be vaginal atresia. In all these conditions will have a secondary amenorrhea. And the other one is the Asherman syndrome. It is nothing but will have scarring in the endometrium, uterine cavity. This may be due to excessive curettage during the previous pregnancy, or abortions, or any DMC procedures, or there is uterine infection in such conditions, or in endometrial tuberculosis, any trans cervical dissection of endometrium. In all these conditions, we'll have a secondary amenorrhea. And after the outflow tract, that is uterus, vagina, and cervix, then we have ovarian causes. In ovarian causes, we have a premature ovarian failure, that is premature menopause. And in PCOS condition, this is the most common condition for secondary amenorrhea. And the other will be the surgical removal of the ovaries, or any radiotherapy, chemotherapy conditions, in autoimmune diseases like thyroid, diabetes, or in conditions where induction of multiple ovulation, infertility leading to premature menopause may also lead to secondary menopause. And the next causes will be the nutritional causes like anorexia nervosa, bulimia, and extreme obesity, where there is excessive eating, binge eating, and excessive weight loss in athletes and ballet dancers. In all these conditions, will have a secondary amenorrhea. And next will be the hypothalamus and pituitary causes. Pituitary causes, coming to the pituitary causes, if there is a hyperprolactinemia or insufficiency, like Sheehan syndrome and Simmons syndrome, and if we are having any pituitary adenomas, we'll have a secondary amenorrhea. And next is the hypothalamic causes. If conditions like brain tumors, anorexia nervosa, GnRH deficiency, stress, obesity, all these are the hypothalamic dysfunction, which leads to secondary amenorrhea. And next will be the endocrine causes. Endocrine causes include thyroid, diabetes, renal disorders, ovarian tumors, and adrenal tumors. All these come under the endocrine causes for secondary amenorrhea. So these are all causes for secondary amenorrhea. Now we'll discuss how to evaluate each and every cause. First, when a patient comes to us, we have to evaluate from the history point. In a history, we have to ask her about the age, her menstrual cycle history, about thyroid, PCOS, because these are the most common conditions for a secondary amenorrhea. And the next will be the associated complaints like thyroid, low estrogen contents, like androgen excess symptoms, like if she's having hirsutism, acne, all these are the symptoms of androgen excessivity. And then CNS disorders, if she's having any behavioral changes or headache, vomiting, visual abnormalities, in all such conditions, all this information should be gathered. And then we have to examine the patient, height, weight, BMI of the patient, and any skin changes. Like in anorexia, there may be some skin changes in the face, thyroid, Cushing's, PCOS, and obesity. In all such conditions, we have to examine. And we have to examine her breast because hyperprolactinemia is the most common cause. And thyroid examination should also be done. And after evaluating about the history and physical examination, we have to go for investigation, that is hormone levels. We have to see random estradiol levels and prolactin levels should be examined. And apart from this, FSH and LH level should be done. The normal values of this FSH and LH will be 5 to 20 international units per ml, and this should be calculated at the mid-cycle peak, and this should be 2 times the base level. And if the levels are below the 5 international units per ml, we'll call it as a hypogonadotropic conditions. And if it's more than 20, we'll call it as a hypergonadotropic. And this is the flow chart. See, this is the flow chart. In the flow chart, what are all the investigations we have to evaluate in a secondary amenorrhea we have described. First, we have to do TSH levels because thyroid is the most common condition, and then followed by prolactin, estradiol levels, FSH, and progesterone challenge test. And finally, through ultrasound, we have to measure the endometrial thickness. Coming to the TSH levels, if it is a high or low TSH levels, both will cause menstrual abnormalities, irregularities in a woman. So high and low TSH will cause secondary amenorrhea. If there are any abnormalities, we'll go with the thyroid disorder and we'll manage her accordingly. And if she's having hyperprolactinemia, that is prolactin levels, 25 nanograms per ml is a normal value. If it is more than 25, then we'll call it as hyperprolactinemia. We have a grades in hyperprolactinemia also, depending upon the value of the prolactin. If she's having hyperprolactinemia, then we have to evaluate. Next step will be we have to go for a MRA screening. In MRA, we have to evaluate any pituitary adenomas or any hypothalamic causes for amenorrhea. And next will be the estradiol levels and followed by FSH and progesterone challenge test. We have to monitor the estrogen levels. If normal estrogen is there, then we'll go with a chronic anovulation diagnosis. And if the estrogen levels are low, then we have to evaluate further steps, that is FSH should be monitored. If FSH levels are more, that is more than 20 international units per ml, then we'll go with the diagnosis of ovarian failure. And we have to evaluate for ovarian failure, that is karyotyping and anti-CYP21 FMR genes should be evaluated. If we are having a normal or low FSH levels, then we have to go for MRA to rule out the pituitary and hypothalamic causes. And this is the evaluation. So coming to the causes in detail, first we'll discuss about the disorders of ovary, then uterine outflow tract, then we'll go with endocrine and other causes, nutritional causes. So coming to the disorders of the ovary, PCOS is the most common cause for secondary amenorrhea. First, we have to know in detail about the PCOS. And then other causes will be the premature ovarian failure and resistant ovarian syndrome like Savage syndrome, hyperestrogenic state like persistent follicles in metropathy and feminizing tumors of the ovary, vascularizing tumors of the ovary. And hypoestrogenic state also causes, that is ablation of the ovaries, pelvic radiation and chemotherapy. All these are the causes for secondary amenorrhea. So coming to the PCOS in detail, as we already all know that this is a condition where we have excessive androgen production and there will be excessive estradiol levels, and the causes will be the multifactorial and it is polygenic condition. And diagnosis of this PCOS, it is depending upon the triad Rotterdam criteria. That is, 2 of the 3 criteria should be present. Coming to the criteria, oligomenorrhea or amenorrhea, that is which indicates anovulation, and the next criteria will be the hyperandrogenic, that is either clinical or biochemical. Clinical will be the clinical diagnosis will be through presence of hirsutism or acne, seborrheic dermatitis, all these excessive hair, unwanted hair, all these are the features of hyperandrogenism. And coming to the biochemical test, we have to go for a testosterone levels. And next, the third criteria will be the polycystic ovaries by ultrasound examination. And coming to the pathophysiology of this PCOS, from hypothalamus and pituitary, there will be increased levels of GnRH and LH levels will be comparatively raised with FSH. And this LH raised LH, this leads to decreased follicular maturation in the ovaries, and there will be increased levels of androgen. This androgen levels, along with decreased sex hormone binding globulin levels, there will be more levels of, we have more levels of free testosterone and free estrogen levels. So this is the main pathophysiology. And coming to the obesity and insulin resistance in PCOS, in obese patients, we have increased insulin resistance. This leads to decreased sex hormone binding globulin, and we have insulin growth factors also decrease. So this leads to increased androgen levels. And this insulin resistance in the ovaries, this leads to excessive production of androgens. And coming to the long-term sequelae of this PCOS, we can encounter the patients with the diabetes mellitus and endometrial carcinoma, hypertension, cardiovascular diseases, and obstructive sleep apnea will also be seen as a long-term sequelae of this PCOS. And coming to the investigations in PCOS, we have to measure the LH levels. These are generally elevated, and the ratio of LH and FSH will be more than 2:1. That is, LH levels will be more than FSH levels, and there will be raised levels of estradiol and estrone levels, and sex hormone binding globulin levels will be decreased. So these are the main investigations. And apart from this, we should test serum testosterone, and the levels will be raised. That is more than 150 nanograms per deciliter. And next is a transcervical transvaginal sonography. In transvaginal sonography, as we already discussed, in Rotterdam's criteria, the third criteria will be the description of the ovaries by ultrasound. That is, the ovaries will be enlarged in volume, and there will be increased number of peripherally arranged follicles, and these should be more than 12. And the cyst should be the size, multiple cysts should be there. The size of the each cyst should be less than 1 centimeter. That is, from 2 to 9 mm, the size of the cyst should be there. So this is all about the PCOS. And next common cause is the resistant ovarian syndrome. This is a rare condition, and some defect should be there in the follicular development. That is, this is due to the intrinsic defects in the follicular development. That is maybe due to disorders in the intra-ovarian regulation or steroidogenic enzyme defects, or any abnormalities in the gonadotropin and the receptors. In all such conditions, we'll have some defect in the follicular development, and this may either present as a primary or secondary amenorrhea. And how to evaluate means there will be increased levels of FSH in such conditions, and these may resolve spontaneously. And those who are presenting with the hot flushes, in such cases only we have to give a treatment with estrogen therapy. And the next is a premature ovarian insufficiency or premature ovarian failure or premature menopause. All these symptoms are same. The incidence is around 2%, and it is defined as amenorrhea for 4 months or more. And this is accompanied by 2 serum FSH levels in the menopausal range for a woman of less than 40 years of age. So the woman should be less than 40 years with 4 months of amenorrhea, and on investigation, the 2 FSH levels should be in a menopausal level. So this is the main criteria for premature ovarian insufficiency, and there will be this is caused by decreased follicular endowment or accelerated follicular attrition. That is, the follicles will partially undergo atresia. And coming to the causes, it can be either genetic causes, that is Turner syndrome, gonadal dysgenesis, trisomy 18 and 13, or X chromosome deletions, translocations, and facile X pre-mutations. All these are the genetic causes for premature ovarian insufficiency. And autoimmune causes will also be there. Infections, hydrogenic and metabolic environmental factors. All these are the causes for secondary amenorrhea. The next will be the what is the pathophysiology and how do we evaluate? If it is an autoimmune disease which causes premature ovarian failure, then we have to screen for thyroid, parathyroid, and adrenal dysfunction. And laboratory evidence of the autoimmune phenomenon is much more prevalent than clinical significant disease. And if it is a chromosomal anomalies which lead to ovarian failure, then we have to go for karyotyping and we have to check for a Y chromosome presence. If we have a Y chromosome in karyotyping, then we have to surgically remove the gonads. And next cause of this premature ovarian failure is radiation therapy. Depending upon age, dose, and radiation field, the damage will be there. And ovaries of the older woman will be more sensitive to effect of radiation than the younger women. And how do we prevent this ovarian failure means electro ovarian transposition before exposure to radiation helps to preserve the gonadal function. And next is the chemotherapy. Chemotherapy, it causes depletion of the primary follicle pool in a drug and dose dependent manner. And depending upon the age and individual susceptibility also, the chemotherapy will affect the ovarian reserve. Coming to the treatment, in our patients with who are undergoing chemotherapy for any malignancy, long-acting GnRH agonist pre-treatment may offer some protection for preservation of the ovaries, that is follicles, and this helps to decrease number of primordial follicles and decrease ovarian perfusion, and then this leads to overexposure to the chemotherapy drugs. And this is all about the ovarian cause of secondary amenorrhea. Next, coming to the anatomical or uterine causes, that is genital outflow tract causes. This is usually due to previous surgery, that is any conditions like ablation of the endometrium by laser spectroscope or any surgical removal of polyps or any submucosal fibroids or cervical stenosis following bone biopsy or loop excision or any Asherman syndrome which is due to the infections or due to excessive curettage during the previous DNCs. All this may lead to outflow tract damage and leading to secondary amenorrhea. How do you evaluate this uterine causes? Means we have to give a progesterone challenge test. That is, we have to give a progesterone dose of either hydroxyprogesterone 5 mg for TID for 3 days or 5 days, and then we have to check for her menstrual cycle. She'll retain her cycle in a 2 to 7 days period. If she has not attained her cycle, then if that is a withdrawal bleeding is absent, then we have to assume that there are no progesterone receptors in the endometrium and it is a diseased endometrium. And then we have to go for estrogen and progesterone challenges. This estrogen progesterone challenges, we have to provide estrogen for progesterone. If still 21 days, and in the luteal phase, we have to support with the progesterone. If there is no withdrawal bleeding, then we have to consider it as a non-functioning endometrium, or if there are any uterine decay, we have to go with this diagnosis, and then for a confirmation, we have to go either for HSG or hysteroscopic we have to confirm the diagnosis. And next is the endocrine causes, that is thyroid and Cushing syndrome. These are the common endocrine causes, and both high levels and low levels of thyroxine will affect the FSH release, and this leads to menstrual irregularities. And other will be the androgen secreting tumors of the ovaries. These also called as secondary amenorrhea. And next is the pituitary causes. Pituitary causes, first we have to evaluate the ovarian, then followed by genital tract, then endocrine causes, and then the pituitary and hypothalamic causes we have to evaluate. Common causes of common pituitary causes which cause secondary amenorrhea, adenoma, especially prolactinomas, that is in conditions like hyperprolactinemia, we have to evaluate about adenomas, and then the Cushing's disease, acromegaly, Sheehan syndrome, Simmons syndrome, infiltrative pituitary diseases like hemochromatosis, lymphocytic hypophysitis, and surgical and radiological ablations. All these are the common causes for secondary amenorrhea. Coming to the Sheehan syndrome, we'll discuss in detail about Sheehan syndrome, and then Cushing syndrome, prolactinomas. Sheehan syndrome, it is generally after first delivery. That is, patients who are having the pregnancy, second pregnancy, having the PPH, that is severe PPH in the first pregnancy, they may land up in a Sheehan syndrome. In such conditions, there will be anterior pituitary necrosis, and the common manifestations will be failing lactation in such cases. And after that, there will be loss of pubic and axillary hair, hypotensive, and secondary amenorrhea will be followed, and there will be atrophy of breast. And on investigation, of gonadotropin and T3, T4, and this is the image in a postpartum hemorrhage with hypotension. There is or postpartum, there will be enlarged pituitary followed by pituitary necrosis. This is a postpartum pituitary necrosis. Is way area. Therefore, followed by long-term sequelae will be the hypothyroidism, secondary adrenal insufficiency, lactational failure, and finally, in a secondary amenorrhea, they land up. And the next will be the Cushing syndrome. Androgens are formed as intermediate products from the synthesis of the cortisol, and Cushing syndrome. This the two different entities. That is a Cushing's disease, which is ACTH dependent, and the adrenal tumor, which is ACTH independent. In these conditions, in Cushing syndrome, the patients will have a weakness and oligomenorrhea or amenorrhea, and followed by acne and hirsutism. Generally, virilization is rare in such conditions. And coming to the screening of this Cushing syndrome, we have to go with the dexamethasone test. This is generally ingested at night during night times at around 11 p.m. We have to ingest the dexamethasone 1 mg and followed by serum cortisol levels tomorrow, the next day morning at 8 a.m. And the levels less than 5 micrograms per 100 ml essentially rule out the Cushing syndrome. And the next will be the pituitary cause will be the hyperprolactinemia. Hyperprolactinemia, the common causes will be either physiological or pathological. Physiological will be during the stress and exercise. If she's having the patient is having the severe stress, or if she is doing exercise, then she will have hyperprolactinemia. In some conditions, she may even have a galactorrhea also. That is a discharge from the nipple. And pregnancy, stimulation of the nipple, sleep, and idiopathic causes. These are all physiological causes of hyperprolactinemia. In such cases, she'll have a secondary amenorrhea. And hypothalamic and pituitary causes of hyperprolactinemia, we have craniopharyngiomas, tuberculosis, hypothyroidism, pituitary adenomas, and Cushing syndrome, acromegaly. And some drugs also cause, like estrogen antidepressants, methyldopa, these may cause hyperprolactinemia. And other conditions like renal failure, decreased prolactin clearance, and cirrhosis of liver, all these causes hyperprolactinemia. So normal levels of prolactin will be around less than 50 to 20 nanograms per ml. If the levels of prolactin are more, that is, if it is around 20 to 50 nanograms per ml, then we will consider it as a mild. And if it is 50 to 100, then it is a moderate. If it is a severe, then the levels will be more than 100 nanograms. If the levels are mild, that is 20 to 50 nanograms per ml, then they have a short luteal. That is, after the ovulation, the luteal phase will be less. She'll have a cycle regularly, and in a moderate conditions, she'll either land up in oligo or amenorrhea or galactorrhea will be present. If it is a severe hyperprolactinemia, then there will be frank hypogonadism with low estrogen levels. And next, how do you evaluate the pituitary causes? Means the same thing. We'll have evaluate first TSH levels and then followed by dopamine levels and prolactin levels. And next causes will be the disorders of hypothalamus. This is generally diagnosis will be through exclusion. That is, after excluding the ovarian causes, uterine outflow causes, and then endocrine, and then causes only we have to go with the hypothalamic causes. That is amenorrhea, and common reason will be leads to decreased leptin levels, and CRH levels and ACTH levels also will be increased, which leads to decreased gonadotropin releasing hormone. So in all such conditions, there will be low levels of SSH and LH, and this leads to secondary amenorrhea. The next will be the nutritional causes, that is weight-related amenorrhea, that is anorexia nervosa, bulimia nervosa, and obesity we'll discuss. In anorexia nervosa, mostly in these patients will have a primary or secondary amenorrhea. This is the first sign. Generally, they'll have a body mass index less than 17 kg per meter square, and they'll present with a menstrual irregularity or amenorrhea. The main cause will be the hypothalamic suppression, and the age will be the 13 to 14 years of age group. Children will present to you. And on investigations, we'll have a low estradiol levels, and the patients will have a risk of osteoporosis. Coming to the features of this anorexia nervosa, 85% of body, they'll have less than 85% of body weight, and they'll have a fear of gaining weight and becoming fat, and the body image will be distorted. They'll have amenorrhea, and the types will be either there will be restricting type or binge and purging type. The next will be the bulimia nervosa. This is episodic binge eating, and they're followed by misuse of laxatives. In these patients, they'll have amenorrhea, and they'll have a fluctuation in the body weight. Generally, they'll present with the menstrual irregularities. And next is the exercise-associated amenorrhea. This is common in a sports person, that is competitive athletes and ballet dancers. This is the most common cause. And eating disorders have a higher prevalence in female athletes than non-athletes. And hypothalamic disorder caused by abnormal gonadotropin releasing hormone pulsatility. This leads to impaired gonadotropic levels, particularly LH levels will be impaired, and then estrogen levels will be decreased. So they'll have a secondary amenorrhea. And the next cause is the obesity. If the woman is having excessive fat cells, then there will be peripheral aromatization to estrogen levels, and there will be decreased levels of sex hormone binding globulins, and this is followed by hyperestrogenic state. Then we'll have anovulatory cycles. And the other causes will be endocrine causes like TSH, prolactin levels, and all these will be increased. So, how do you evaluate, finally, if a patient comes to you, how do you evaluate means? First, we have to assess the clinical assessment of the patient through history and evaluation, then followed by her estrogen status, followed by TSH, prolactin levels, and FSH. On vaginal ultrasound examination, if we are having a AFC count, that is antral follicular count in the ovaries, or less, or more, then we'll see the diagnosis. If the antral follicular count are less, then we'll have a diagnosis of either PCOS or premature ovarian insufficiency. We'll go with the diagnosis of this, and we can have assessment of endometrial thickness also. And next, after ultrasound examination, we'll go with imaging of the pituitary and hypothalamus. Um, if prolactin levels are elevated, or if she's having hypothalamic amenorrhea, then only we have to go for imaging of the pituitary and hypothalamus through MRI. So this is in brief of investigations of secondary amenorrhea. First, we have to exclude the pregnancy, and then followed by the serum TSH and prolactin levels. Then, if she's having high levels of prolactin and TSH, then we have to go with the CT and MRI reports. If she's having after exclusion of these pregnancy, we have to evaluate the progesterone challenge test. That is, as we already discussed, we have to give a progesterone for a course of 5 days. Then, if she's not having any withdrawal bleeding, then we'll go with estrogen and progesterone challenge test. That we have to give her estrogen along with progesterone. And if still she is not having her cycles, then we have to evaluate FSH and LH. If she's having high FSH, then we'll go with the ovarian failure and resistant ovarian syndrome. And if she's having low, then we'll go with hypothalamic or pituitary lesions. And with the diagnosis of hypothalamic or pituitary lesions, then with GnRH dynamic test. If it is a positive, then we'll go with the hypothalamic causes. If it is a negative test, then we'll conclude it as a pituitary causes. And before this test, we have to evaluate the endocrine causes, that is TSH and prolactin levels. If TSH levels are more, then we'll go with the diagnosis of hypothyroidism. If after treating this hypothyroidism, then she'll have a regular cycles. Or if she's having a prolactin levels, high levels, then we'll go with the diagnosis of hyperprolactinemia, and then we have to evaluate with X-ray or MRI. In MRI, if you are having any pituitary adenomas, we'll have to treat the such conditions. So this is all about secondary amenorrhea. So far, we have discussed what are the causes, physiological and pathological cause of secondary amenorrhea. In physiological, we have discussed about pregnancy, lactation, and menopause. And in pathological conditions, we have described the outflow tract causes, ovarian causes, most common causes of PCOS, and then followed by endocrine causes, and then nutritional causes, pituitary causes, and hypothalamic causes. And how to evaluate also we have discussed. In evaluation, first we have to exclude the physiological causes, that is pregnancy, and endocrine causes we have to rule out before going for any other medication. That is, TSH and prolactin levels should be evaluated, then followed by progesterone challenge test, that is progesterone we have to give her. And if she's not having any withdrawal bleeding, then we'll go with estrogen progesterone. And if still she's not having any withdrawal bleeding, then we'll go with the FSH and LH monitoring. And depending upon the levels of FSH and LH, if it is more than 40 milli-international units, then we'll go with ovarian failure and resistant ovarian syndrome. And then, if, depending upon the age, we'll go with the karyotyping. And if the low levels of FSH are there, then we'll go with the hypothalamic and pituitary causes. In after that, how to evaluate hypothalamic and pituitary means we'll go with the GnRH dynamic test. If it is a positive, we'll go with hypothalamic causes, and if it is a negative, we'll go with the pituitary causes. So this is in detail about secondary amenorrhea. Okay, if you are having any doubts, you can ask me. I'll forward you the PPT. You can, if you can see if you have any doubts. Okay, if you are not having any doubts, we'll end up here.